Good evening and welcome back to the Canadian Concussion Centre webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series that was developed for individuals that are struggling with symptoms of concussion, as well as their caregivers and healthcare providers. Sessions, if you haven't been with us before, start with an expert speaker who speaks to different aspects of concussion and symptoms. And then that is followed by a question and answer period where you can get your questions answered. And again, for those of you who haven't been here, our sessions run every 2 weeks on Tuesday evening from 6 to 7. Just before I go any further, I'd like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we are meeting virtually, I'd like to take a moment to acknowledge the importance of the lands which we all call home, to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So just in terms of your questions tonight, you'll see if you look to the bottom of your screen, you'll see a Q&A. If you have any questions for our speaker, please enter those there. And if you have any technical questions, please enter those into the chat and Christian can give you a hand. We're just going to run a short poll, as we always do, just to get a sense of who is in our audience. I'll just give you a second there. And great. So for this evening's session, I'm really pleased to welcome Dr. Carmela Tartaglia, who is back with us presenting Concussion and Invisible Brain Injury with Consequences. Dr. Tartaglia is an associate professor at the University of Toronto and cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She's a scientist at the C.E.T.S Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. The ultimate goal of her research programs is to develop biomarkers for early detection of disease so as to provide targeted, personalized treatments to her patients. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And with that, I will turn it over to Dr. Tartaglia.
All right. So thank you for inviting me. And these are my disclosures unrelated to this topic, unfortunately. So I'll just start with types of brain injuries, which you probably all know. Concussion, mild traumatic brain injury, they're often used interchangeably. They aren't exactly the same, but we often think of concussion as a milder form of the mild traumatic brain injury. And basically, we expect people, if they're, if they lose consciousness, that it be for a short period of time, so less than 30 minutes. If they have post-traumatic amnesia, which means forgetting before or after the event, it should be for less than 24 hours. If they have impaired mental status, which often occurs at the time of an accident where people can get confused or disoriented, that is short-lived. And, whatever neurological problem there is, it should be transient. And of course, this is to separate this injury from the moderate to severe traumatic brain injuries, where you get bruising or contusion on the brain, tearing, laceration, and bleeding. And so concussion is really thought of as an acute brain effect of blunt impact or other mechanical energy that's applied to the head or other part of the body, such that there is a force of acceleration, deceleration, or rotation. And again, it doesn't need to be directly to the head. Anywhere or a whiplash injury can cause a concussion. And usually you end up with an immediate and a temporary alteration of mental functioning. It's a growing epidemic. I don't need to tell people that, we increasingly recognize that it is very common to have mild traumatic brain injury or concussion. And honestly, all the numbers that you will see are an underestimate, because oftentimes people will not seek medical attention. Many times people will, wait it out, and only if their symptoms last for, days, if they're, feeling really unwell, will they go get medical attention. So recent numbers, and, maybe even these are an underestimate, put about 150,000 Ontarians having concussions per year. And the issue about concussion is it's a clinical diagnosis because there is no diagnostic test. There are, oftentimes people promoting different types of biomarkers, but these are mostly biomarkers that can be used to identify a more severe head injury and not for concussion, whether it's imaging or blood biomarkers, all kinds of things. And the issue is that a concussion, it happens to a person, and we're all very different from each other. And as well, the injuries can be very different. And so it's often not easy to find two people who suffer the same after a head injury. In terms of diagnosis, the MRIs would be done to rule out other more serious problems, but they aren't done to diagnose the concussion. And so many times we don't actually do MRIs for concussion. And when people think about the symptoms that they end up with after concussion, you have to think, well, those symptoms come from the brain. So what's happened to the brain? And, in all honesty, we don't actually know. People have put forth many different theories on what's happening to the brain to give you all those symptoms, but we don't really know. And one of the things that people have started to look at is, well, the injury, what happens, where does it happen? And there's some evidence that the brain stems, and especially the top of the brain stem, so the part in green on the picture on the far left, is where there may be some rotational force. As well, when you think of the areas of the brain that are maybe the most often impacted, well, we think of the frontal lobes and the temporal lobes, so the parts in red, green, and yellow on the picture on the right. And that's because those places are really, really, those parts of the brain are really close to bone. And then when we think of all these neurotransmitters, these things in the brainstem that would have an impact, that would be impacted the most by this, well, those areas are really important for making what we call neurotransmitters. These are chemicals that are made in a certain area of the brain, but they really travel the whole of the brain to interact with many different parts of the brain. And it's important to realize that that part of the brain has, what we call cholinergic neurons, and those are important for making a molecule called acetylcholine, which is important for attention, dopamine for reward, happiness, serotonergic, which are for mood, noradrenergic for autonomic regulation. And so when we think of all the symptoms that could happen, one must remember that the areas of the brain that are maybe most affected are areas that are very important for a wide range of functions. And so when you think of the symptoms that can come out, well, obviously that's why we end up with a huge array. And so, people will complain of cognitive symptoms like difficulty thinking, slowed processing, difficulty remembering, personality, mood changes, irritability, depression, anxiety, difficulties with sleep. And of course, all the physical symptoms like headache and blurred vision and dizziness and sensitivity to light or noise, fatigue, nausea. And, luckily, most people recover. When I said these staggering numbers of concussion, and so, if a lot of people didn't recover, we would be, in much more trouble than we are. But usually, and that is, in some cases, 85, 90% of people have a complete recovery. That usually takes less than 14 days in adults. Now, I have to say that a lot of these numbers came about when we used to give people 3 months to recover. And so I'm not certain the numbers are so high at 2 weeks. And I have to say that, I think the more honest numbers are around maybe 75 to 80% of people make a full recovery in a short period of time. And for many people, it takes quite a while to make a full recovery. When people have looked at neuropsychological function, they've said most people return to normal in 5 days. And that's why people were given this 2 weeks. And the injury is really a diffuse injury. And so we don't expect to see any focal signs in the cranial nerves or motor or sensory exams. What about persisting symptoms? Well, I've said right now the guideline is after 2 weeks, we start to think this is more persisting. But we usually give people at least a month. It used to be 3 months, but we don't really want to wait 3 months to consider that somebody needs, extra attention. We don't presume an underlying cause, and that's because we actually don't know what's going on. Although people talk about animal models, so far we have really no good models of concussion. And we really take a symptom-based approach. So regardless of the cause, we focus on the symptoms. And so, when we think of, well, what is the combination or constellation of symptoms? Well, it's very, very heterogeneous. And, it turns out that there's a lot of people, even in Ontario alone, if we calculate 15% of the 150,000, that's 23,000 Ontarians per year that would endure prolonged symptoms. And like I've said, the persisting symptoms of concussion largely overlap the ones that happen right after a concussion. But, probably there's more of the psychiatric symptoms that start to occur after, 2 weeks versus initially where we have a lot more of the physical symptoms. But when we're thinking about, how to, consider or frame this injury, is that the injury has consequences. But the problem is that a lot of the consequences of concussion actually give you other symptoms or make other symptoms worse. So for example, post-concussion, people will often have what we call somatic symptoms. These are the physical symptoms, and they'll have trouble with sleep, and they'll have pain and headache and dizziness. Also, post-injury, people can have mood issues like depression or anxiety. And of course, they can have cognitive symptoms like trouble with concentration, feeling like they're slow, not being able to remember, word finding difficulties. But then you have to remember that the somatic symptoms will also make the cognitive symptoms worse and make the mood worse. And the low mood, the anxiety will make the cognitive symptoms worse and make the somatic. And so really, we start to deal with this vicious cycle that happens in concussion. And to try to get anywhere, we really take a symptom-based approach and try to intervene so that we can get the gears going again, so that we can start to make a little headway in recovery. Let's talk a little bit more about the cognitive symptoms that people end up with after a concussion. The common ones are impaired attention, concentration, slowed information processing, memory, and what we call executive function or attention working memory. Patients should get assessed for this. And the cognition usually improves within 6 months when people start to have these symptoms. But of course, it's unclear whether the persisting cognitive symptoms result from the effects of the injury or from a lot of the factors that influence cognition, like pain, fatigue, medications, poor sleep, psychological factors. And we know this because actually, in many different injuries, in many different types of conditions, we have these cognitive symptoms getting worse, and they're not related to the initial injury. They are related to all the other things that are going on. And so we do understand, and we do know that it is important to treat these. And one thing that I tell people, cognitive symptoms don't worsen over time when you have a concussion. So anytime that we see that, we start to worry that there are some other things going on that are making the cognitive symptoms worse. And usually it's because of poor sleep, poor mood, or in some cases, something else. Post-traumatic headache. This is a headache that develops within usually 7 days of the concussion. And It's the most common symptom after concussion. Its prevalence in most studies is close to 90%. There's a few that, report lower numbers. And many people don't even report this because they don't even think that it's a post-concussion symptom. Studies have shown that the mean age is usually younger. Females are seen to be at higher risk, and it's associated with a high degree of disability. Now, the acute post-traumatic headache is really one that develops within 7 days after the trauma. And there's something called a chronic headache that also develops within 7 days, but lasts for over 3 months. And I have to say that it isn't infrequent that I see people who have had headaches, constant daily headaches for months, like 6 months, 9 months, 1 year, without any preventative therapy. And then, of course, they're complaining about their cognitive function, but a headache is very distracting. And so it is not unusual. It actually can be expected that if you have constant daily headaches, you will end up with cognitive deficits. The types of headache after concussion is very interesting because they actually take all different types of forms. And so, they can be tension-like or migraine-like. Some people will just have sensitivity to light, sensitivity to sound. And I put all those things into the headache spectrum. And so we try to prevent them with medications that actually prevent headaches. And what happens a lot of times in the patients that I see is that, unfortunately, they have constant daily headaches, which are debilitating. And so they start using Tylenol or naproxen or Advil or any of these other over-the-counter medications, and then end up with medication overuse headaches. Some medications actually are prescribed, not even over the counter. And if you're taking more than 14, using these medications for more than 14 days per month, you're highly likely to end up with a medication overuse headache. And so that becomes even harder to treat. And so we really encourage people that if they've had constant daily headaches for, close to a month, that we start thinking about what are we going to do to prevent headaches. And then neuropsychiatric symptoms. People really underestimate the high rates of neuropsychiatric symptoms that in many studies can be in the 60% range. The more concussions a person has, the higher their risk. A lot of times they'll have more than one psychiatric disorder. Post-traumatic stress disorder is actually very common. There can be comorbid conditions. People can develop substance abuse, obviously, after a concussion, like anything else. And of course, if a person has a psychiatric condition and it was well controlled, it can also get worse. There are some risk factors for persisting symptoms, and this is a growing literature because, if you look at 10 different studies, they have different factors, but a few of the consistent ones, let's say, are history of prior concussion puts you at higher risk of persisting symptoms. Female sex puts you at higher risk, younger age, mood disorders, and a previous headache. But we think of when people have concussion that, it happens on the landscape of a person. And so there are medical factors that can make that can put you at a higher risk of post-concussion symptoms. And there are contextual factors, so things that the person is experiencing that can also put you at higher risk. And so it's important to factor these in because, when we see people, that person wants to know whether they're going to get better and how fast they're going to get better. And so if you want to make any type of, prediction, you really have to take a personalized precision type of approach and really consider these medical and contextual factors. And why should we care? Well, prolonged symptoms are often non-specific and that there are other things that can make them worse. And the issue is that, it becomes difficult to make a diagnosis, but the symptoms secondary to concussion overlap, other things, and all this can make all the symptoms worse, including the medication side effects. And so, when you're trying to treat people and trying to, discuss with somebody, like, how are we going to make them better? It's important that people understand that all these things work together. And, I often tell people our brains are made up of these like gears. And if you end up with a concussion, sometimes the gears just all stop because you have this multitude of different symptoms. And so then it's a matter of trying to figure out how are you going to get these gears going? And sometimes, by treating a headache, by treating sleep, by, helping somebody with their fatigue or their mood, you can get these gears going. And oftentimes the cognitive symptoms will improve with that. So how do we treat? Well, we take a symptom-based approach. So we treat the symptoms. If there's mood, we use antidepressants, cognitive behavioral therapy. Headache, we try to prevent the headaches by giving people medications. Sleep is a big issue. We do sleep studies. If we find sleep apnea, it needs to be treated. Vestibular physiotherapy for balance issues, often seen after a concussion. Low impact exercise, there's a lot of evidence for this. And then a modified return to work, school, play. It's very important to consider that because we have evidence that returning to your activities is associated with a better recovery, even in people who aren't fully recovered by the time they go back. So I'm going to change gears again at this point because I want to talk about the delayed effects of concussions and mild traumatic brain injury. So until now, we really focused on, you have an injury and then people have persisting symptoms of concussion. But a few years ago, it was reported that actually all brain injuries, including mild traumatic brain injuries or concussion, can increase your risk of dementia later on in life. And so a Lancet report came out in 2020 and traumatic brain injury made it to that list. And it was based on large studies done over many years. There was a large one where 178,000 veterans with some traumatic brain injury and finding that there was a higher risk of dementia if you had a higher traumatic brain injury, but also even one concussion could increase your risk. And so head injury made it to the list of 12 modifiable risk factors for dementia. And so it included the ranks of physical inactivity and smoking and air pollution, obesity, depression, diabetes, high blood pressure, low education. So you can see that, there are a number of different types of risk factors that have been found over time to increase your risk of dementia. Now, it's important to understand that when we increase a risk, that doesn't mean that you get what, that if you have one of these risk factors that you will automatically get dementia. It just, there's an association, this increased risk after head injuries. The one consequence that people have, paid most attention to, this entity of chronic traumatic encephalopathy, which is this progressive neurodegenerative disease, seems to evolve slowly over decades. The symptoms usually appear after years after injury, and it was first described in boxers, but it's been now described in hockey, football, other sports, the military, motor vehicle accidents, and in abuse. CTE outside of athletes actually is hardly ever found. When people have looked in these large brain banks, they find very, very low incidence. And to date, most people think that all these people had played or were involved in activities, that there was some form of repetitive head injury. And, this is a large study that came out of Manitoba. So, just the administrative data that looked at, it was a 25-year retrospective study, and from 1990 to 2015, and included 28,000 males and 19,000 females who had concussions, and then compared to 81,000 men and 57,000 females without concussion. And they looked at dementia, attention deficit disorder, Parkinson's disease, and mood disorder. And, these are the risk for dementia diagnosis, and was found to be higher at 1.7, for Parkinson's disease, higher risk of 1.6. And so, they report, regardless of age, sex, socioeconomic status, residence, having suffered a single concussion increased the likelihood of being diagnosed with Parkinson's, dementia, attention deficit disorder, mood and anxiety disorders. And there is some evidence, these are large numbers of studies that show that, having a mild traumatic brain injury in your history did increase your risk of being diagnosed with Alzheimer's disease. And this is obviously in late life. Again, this is looking at Parkinson's disease and looking in a brain bank where, these are the religious order studies. These were these nuns who donated their brains to science, on Memory and Aging Project. And again, looking in these large databases showing that a traumatic brain injury, most of them, did not had loss of consciousness, but there are some even without loss of consciousness showing that there was this association with Parkinson's disease. Motor neuron disease, or ALS, I know if other people have heard of it as Lou Gehrig's disease. There was a connection that was, I guess, insinuated in the soccer players, and a large number of studies put together did show that people who had head injuries seem to be at higher risk of ALS. But it's important to remember that when we talk about these studies that are showing, that there's an increased risk, that an increased risk doesn't mean you are destined to get this illness. And, traumatic brain injury has made it to the list of 12 modifiable risk factors for dementia. So it's really important to remember that, because there are many things on this list that we can actually do things about. The level of physical activity is completely under our control. So I always tell people, if you have one risk, like you've had the head injury, you can't really change that, it's already happened, then I think it becomes even more important to really focus on these other modifiable risk factors so that you can mitigate the one thing that has already happened to you and you can't change that. So, I encourage people to become more physically active, stop smoking if they're smoking, stop, or reduce their alcohol intake. The new guidelines are for less than 2 a week. Social activities, very important. Being obesity has been associated with dementia. And so, making sure that you have your weight under control. If you have a hearing impairment, to have hearing aids, having the depression treated, having good diabetic control, good blood pressure control, furthering our education. And so there's many things that are under control, even if we have had a brain injury. And so to summarize, concussions are the result of brain trauma. Symptoms are varied, and they include cognitive symptoms, they include physical symptoms, they include psychiatric symptoms, and persisting symptoms can occur. And so it's important to target them so that we can, get people better by fixing the fixable symptoms. Concussions are implicated in the delayed neurodegenerative disease, and there's evidence in Parkinson's, in Alzheimer's, in ALS, and in CTE. But there are things that we can do that are under our control to mitigate that risk, so that we reduce our risk of dementia. And that's it. Thank you. Happy to take any questions.
Great. Thanks so much for the excellent presentation. I'm just going to open it up. It looks like we've got a few questions already. So just a reminder for any of you that have questions, please just enter those into the Q&A. So the first question is, what is the chance of returning to a pre-concussion routine, exercise activities such as jumping rope, doing Zumba, and those, I guess, any types of physical activities where your head may be bouncing?
Yeah, I think the chance when you're fully recovered is very high, but these are activities that we would not consider low impact. So while people are in the recovery mode, I usually recommend that people do low impact exercise. Now, some people have no trouble with this, even if they have headaches. The exercise doesn't exacerbate it. So good. go for it. But if these kinds of exercise exacerbate your headaches, then I would say stay away from them until your headache resolves or you feel completely better, and focus on things like stationary bicycle or swimming, even, some people can row, others don't, elliptical, but doing things that aren't, jostling the head so much.
Great, thank you. Next question. When people with persistent symptoms of concussion get COVID, what happens with their symptoms and are they more likely to get long COVID?
Yeah, I mean, that's a great question. I actually ended up with a long COVID clinic, which luckily has almost completely decimated itself because I don't really have that many customers anymore. But what happens is that if you think of the long COVID symptoms, there's a lot of overlap with concussion symptoms. And so I often get people who were getting better from their concussion, and then they ended up with COVID. And it's like they had a relapse of a lot of their concussion symptoms. Their headaches got worse, their sleep got bad, their, mood deteriorated, they had brain fog. And so there is a huge overlap, and we do hear a lot people recovering from concussion feel like they've had a relapse, and then slowly they get better from the concussion and the long COVID. Again, when we don't have any biomarkers for each of these things, we don't, it's hard to tell what's the biggest contributor.
Okay, thank you. Many people who have persistent symptoms like daily headaches for more than 5 and even up to 10 years, and they're asking why that would be.
Yeah, I have to say, I have very few people who have headaches that long who haven't been able to get better. There are some, we do, even in primary headache disorder clinics, we do have people who have chronic headaches. Most people with some prophylaxis, which are, medications that you take every day to prevent headaches, they do get better. It can sometimes take months of medications to get them better, but a lot of times they can. Now, do some people end up with more, persisting headache symptoms? Yes. I find one of the risk factors for that is people who have had these constant daily headaches for years, and they're, been taking Tylenol and they're not treated, then it's really tough. But there actually are some new headache medications that are really made a huge dent in the well-being of people who have been chronic headache sufferers. So it's worthwhile trying to get to a headache clinic with a headache specialist.
Great, thank you. I was diagnosed with a labyrinthine concussion. Can you explain that?
No, because labyrinthine to me means, the labyrinth in our inner ear. And so you can end up with a concussion that causes damage, an injury that causes damage to the inner ear. And so you end up with symptoms related to the inner ear. So it could be, vertigo, most likely. Sometimes people end up with tinnitus. We're not even really sure where that comes from. But I'm not sure I've ever heard it diagnosed as labyrinthine concussion, because it's the injury. A concussion is the injury that you get, and it's not the injury to the inner ear. I'm not sure would be called a concussion. We usually think of that as being an injury to the brain, but maybe I'll have to look that up.
Okay, yeah, thank you. Can PCS or persistent post-concussion symptoms lead to digestive issues like constipation and problems with digestive motility?
Well, I'm not sure directly, but I hear some of these issues. And okay, so one of the things that we often hear after concussion is nausea. Nausea is part and parcel with headaches. So lots of people get headaches and they get nauseous, and sometimes they have nausea and they don't even get the headache. So I hear a lot about that. The medication that we take, some of them do cause Well, a lot of pain medications cause constipation. So I'd be more worried about that. Because of a direct effect, I actually have not heard of. I don't know if Leslie, you've heard of or you've seen that.
No, not directly. No, no. I mean,
Mm.
there are probably different pathways that could lead to those problems, but no. Okay, I think you kind of addressed this one, but I'll ask it again. Is there any way to reduce the likelihood of getting Alzheimer's if you have had more than one concussion?
Yeah, I think, like I've said, even people with repeated concussion, it's not like a perfect relationship, right? It's not because you've had repeated concussions that you're automatically going to get Alzheimer's disease. I see a lot of professional athletes and they don't get Alzheimer's disease. So it's not a one-to-one relationship. I think what's really important is all those other things that we know have evidence for improving your brain health. And so that's things like exercising, making sure you're learning new things, keeping, being social. There's lots of those other factors that have huge impact and may even have a larger impact on your risk of dementia, and should be focused on.
Great, thank you. Okay, we have a bit of a longer one here. I'm a physiotherapist, and where I work, often patients are referred to for concussion management. My question has to do with patients with undiagnosed and untreated anxiety disorders, ADD, ADHD, etc. These patients have the characteristics of being impulsive, boom bust behavior, difficult pacing themselves, fast, over talking, and others that basically fly into the face of how concussions need to be addressed. They fail to rest sufficiently and are at risk of having prolonged symptoms and recovery, and likely incomplete recovery and long-term disability. When there is no family physician, how can I best advocate for these patients to get proper care so that the concussion piece can be worked on?
Yeah, I think that's a great question and difficult, because a lot of the symptoms you're talking about actually, some of them might need a psychiatrist to evaluate, right? And so I think, it's very difficult when there's no quarterback for the patient. There's alternative types of care, right? I mean, there's some walk-in clinics that have physicians, they have nurse practitioners. But yeah, I agree. It's very difficult. It's very difficult for us because a lot of patients have lost their family doctors, and they don't have any primary care. And so I agree, those things need to be addressed. But some of those actually belong to the realm of psychiatry. And I think that's, unfortunately, you need a referral for that. So yeah.
Yeah, it's a good question. Marika is asking, is there any connection with having had a concussion and being predisposed to multiple sclerosis?
Yeah, that's a good question. The literature is kind of indeterminate on that. We're trying to look at that. I would say right now the data we have is it does not seem to be, but I would say it's not clear. You have to remember concussions happen across the ages, right? And multiple sclerosis, and actually some of the highest risk groups are older groups in some cases. And multiple sclerosis is a disease that is usually diagnosed when people are fairly young, much more prevalent in women. So it's hard to know, right? The epidemiology doesn't necessarily work in in an aligned way, but I would say the jury's still not out on that.
Okay, thank you. Is taking 2 extra strength Tylenol a day for headaches considered overuse?
If you do it for more than 14 days in a month, yes.
Okay,
Yeah.
great. Uh, Also, is there any relation between concussion and autonomic dysfunction?
Yeah, I mean, it's a good question, and sometimes people will say, they have feelings of, changes in their heart rates or blood pressure, and one could, I guess hypothesize because, there could be some problems that come from, this injury that's in the brainstem. But I would say that the evidence for it is not been conclusive. When people have actually looked with methods to detect autonomic dysfunction, we haven't found it. Also, a lot of symptoms of autonomic dysfunction, whether it be like changes in your sweating pattern or your I mean, that's a common one, or blood pressure control. Uh, they're not that prevalent in terms of concussion symptoms. So yeah, hard to tell for sure.
Okay. And then this one is sort of following on that. How can someone with persistent post-concussion symptoms, I think, and whiplash get proper help for dysautonomia or orthostatic hypotension? Many doctors don't seem to specialize in this, and therefore treatment is difficult to obtain. Are there any treatments that can be helpful?
Yeah, I mean, I think the issue is that you need to do the testing. Some of the ear, nose, throat doctors do that. They do like a tilt table test. There are some other physicians, I think in cardiology, also looking at these things. So with COVID, there actually are a lot more clinics doing these assessments. And yes, there are treatments for it. So if people find that their blood pressures can drop, they, there's certain medications they can try. But the even though a lot of patients have autonomic symptoms, they don't meet criteria for a diagnosis of autonomic dysfunction. And so we have to separate those two things. People can feel unwell, but to have a diagnosis of dysautonomia from orthostatic hypotension, your blood pressure has to fall a certain amount. And if it does, there actually are treatments for that. But they're only useful if you really have this, because the side effects of those treatments in some cases can give you very high blood pressures. So it's not trivial. But ear, nose, throat doctors often will do that assessment. And I think now there are some clinics, some POTS clinics, because of long COVID, who also do this kind of assessment.
Okay, great. Thank you. This next one, I've had I don't know if this is a typo, but she's saying I've had my maybe three different types of headaches since I hit a moose over 6.5 years ago. For over a year, I've been receiving 39 injections of Botox every 3 months. It does help, say 60 to 70%. Are there any long-term issues with getting Botox since they're also getting it in their jaw?
Yeah. Well, I am impressed that you hit a moose and you are alive to talk about it, because oftentimes we hear the opposite. So I'm glad to hear that. Um, yeah, I mean, it is a lot of Botox, but I think there are people, chronic headache people, who receive Botox, and if it is helpful, one would hope that eventually you actually won't need it anymore if you didn't suffer from headaches before. But I would speak to the person giving you the Botox. We in neurology, we have people who have dystonia. So it's a kind of like muscle tightening, and these people can receive Botox for decades. So I think, it's probably okay. But I would speak to the headache specialist that's giving you the Botox, because they'll know the best.
Okay, great. Thank you. Is there a connection between concussion and social emotional learning disabilities?
Hmm. Yeah, I don't know. I guess I would assume social emotional learning disabilities is something that happens when you're very young. I mean, I would assume that's when you get diagnosed with that. So if you had a concussion when you're really young, um, definitely people who get concussions feel like older people, which is, I don't see, pediatric cases, tell me that they feel like they've changed, mostly related to, changes in their personality, like as it relates to irritability and, low mood and being more withdrawn, extroverts who no longer really want to hang out with people. Um, but but they would be at an advanced age. And so we would not be making an advanced age. I mean, where they're in their 20s or 30s. And so I'm not sure we would be making a diagnosis of social emotional learning disabilities in these people. I have to say, I've never heard that term. So yeah,
Yeah.
I'm at a loss.
Okay. Thank you. The next question is, who can develop CTE and can it lead to Alzheimer's disease?
Yeah, so CTE is chronic traumatic encephalopathy. And so that's a neurodegenerative disease like Alzheimer's. So Alzheimer's is a neurodegenerative disease and CTE is a neurodegenerative disease. CTE, its only known risk factor to date is repetitive head injuries. So, can you have a person who has CTE? So we find it when they die. And can they also have Alzheimer's disease in the brain? Yes, they can. So if that's your question, you can have both CTE and Alzheimer's disease pathology in the brain. Actually, a lot of people who have neurodegenerative disease, they have multiple pathologies in the brain. It's actually very rare to have only one thing. But CTE doesn't necessarily give you Alzheimer's because there's some people who will die with only CTE in the brain. There's some people who only die with Alzheimer's disease in the brain. So they can ride together, but they can also ride apart. Yeah.
Okay. Thank you. If you've had many concussions, are there any specific watch programs or long-term studies one can join for dementia symptoms?
Yeah, I mean, that's a great question. We used to have one where people who had persisting symptoms of concussion, and now we have studies where we look at that, but it's actually people who have already cognitive impairment or at risk of a neurodegenerative disease. So I don't actually know of any studies right now that are recruiting people who've had concussions and we just follow them. Like we have one, but it's more for these contact sports athletes who have had like many concussions. So that's a good question. If I think of one, I will send it out and
Yeah.
I'll send it to the coordinator here.
Does red light therapy help with headache?
Well, I don't know because I've never heard of that. So yeah, sorry.
Okay. It's a NUCCA, NUCCA chiropractor and or a functional neurologist, the type of professional someone with a whiplash would safely want to see if traditional physiotherapy has not relieved symptoms.
Yeah. I'm not sure what a functional neurologist is. I don't know if it's a neurologist that specializes in functional neurological disorders, and if so, not sure that's the person. Nuka chiropractor, I have really no idea. But the type of physician I send patients to who have persisting whiplash symptoms is a physiatrist. So it's not a psychiatrist, it's a physiatrist. And these people specialize in musculoskeletal. They have a good neurology background also. And so they are well versed in musculoskeletal. They're well versed in also whiplash injuries. But yeah, that's who I would try to see if had persisting symptoms that didn't get better.
Great, thank you. I'm just going into the chat. So there's someone asking, my daughter at 6 years old got into a car accident. Sounds like she had a head injury and neck dislocation. As of now, she's 10 years old. And after the accident, we have had a problem with her sleeping. Because she can't express herself, it is difficult for me think to know whether she has a headache or not. Do you think the changes of her sleeping is due to the accident? Uh, any suggestions?
Yeah, I mean, for sure, after a brain injury, people can have changes in their sleep. So it could be related to that. And, you know, if she isn't verbal, uh, I work with different patients, a different patient population that isn't verbal, but there's usually some kind of sign when they aren't well. So in my uh, patients, sometimes they will grimace. There'll be some changes in terms of their demeanor. They may become agitated if they have pain, even if they can't tell you that. So I'm not sure if that applies in this case, but I would look for any change to her usual behaviors to know if she's having a headache. In terms of therapy, um, yeah, it's very difficult. I mean, I don't treat children who are 10, so I don't know what I would give. You know, we do have medication, a new medication that's come on the market for adults. And unfortunately, it's not covered by OHIP and is quite expensive, but I'm not actually sure if it's indicated for children. Um, but it's called lemborexant, Lemborexant. So you can look into that. Um, uh, I think I think sleep is so important because it does make, you know, we need sleep to feel in an optimal way the next day. And so, yeah, I guess trying to fix her sleep as best as possible. But yeah, I might try to go see a sleep specialist if I were you. And I see you said she gets agitated easily. Yes. It you know, sometimes when people have baseline headaches, um, they it is easier to become agitated. So something to think about, whether she still is having headaches, although it's many years out now.
Mhm. Okay, thank you. Sue's asking a question. I hear more about people being diagnosed with suspected CTE. Given that CTE can only be diagnosed on autopsy, how do you make a diagnosis of suspected CTE?
Yeah, well, that's incorrect. They should not making that diagnosis. You know, we you are correct. We can only make diagnosis of CTE after people die. We have no proven biomarkers for CTE. All of us, well, not all of us, but many of us have active research programs in this. But right now, we have no diagnostic test for CTE. And so you know, there actually were a few years ago these guidelines on, you know, diagnosing the traumatic encephalopathy syndrome, which is the clinical syndrome that was presumed to be caused by CTE. And it was shown that the criteria are very poor for making a diagnosis of pathological CTE. So, you know, you get a diagnosis of, you know, traumatic encephalopathy syndrome while you're alive, and then you know, the whole point would be you die, we look at the brain, should be CTE, but actually there was no relationship. And if you look at those criteria, many people with depression could meet criteria also. So right now, unfortunately, we list it always as a possible diagnosis when somebody comes to us and they've had repetitive head injury, as usually seen only in contact sports.
Okay, great, thank you. Couple more questions. I think it's when I am experiencing confusion, then I know to pull back on activities. This is after a concussion. Are there any indicators how the concussion is healing?
Yeah, I think that's a great question. And, that's the issue, is that because we don't have any biomarkers, we just go with your symptoms. And that being said, we don't actually know that something is still wrong, in the sense of something wrong with the brain. And so I always tell people it's okay to have symptoms for a little while. If you do something and it brings on a little bit of a headache, it's all right to do some activity with a little bit of a headache. What we don't want is people to push themselves to the point where they end up debilitated and in bed for 2 weeks. So I think you're the best judge of yourself, but it's okay to have a little bit of confusion for maybe like 15, 20 minutes, half an hour. But then when it starts to go on with that, then maybe, I would, pull back, and then over time, slowly ramp up your activity.
Mm-hmm. And actually, following on that, I've had 3 concussions over 5 years. I'm exercise intolerant. And they're asking, how does a PT help with exercise intolerance?
Yeah, I mean, I think trying to find the exercise that you're not intolerant to. So, I tell people, it's like, start by sit on a stationary bicycle and pedal without any resistance. You should be able to do that, because that's actually almost the same as walking. And so, it's a matter of finding an activity that you can do, and then tricking yourself almost into finding ways to ramp up that activity. So you can walk. Well, maybe you, for 5 minutes, pick up the pace. For 2 minutes, you climb some stairs. And so slowly you ramp up that activity, because you have to remember something. If you add deconditioning to symptoms of concussion, you make matters worse. And for sure, if you have not been exercising, the first few times you exercise, you're not going to feel great. That's just a matter of fact, because the reason exercise is good for you, aerobic exercise, is because there's actually these chemicals that are released when you exercise. And if your body isn't used to those chemicals anymore because you've been sedentary, well, your body has to get used to them again. Your brain has to get used to seeing these chemicals again. So finding little ways to become more tolerant of any type of exercise.
Great, thank you. I'm just checking the time. We got a couple more minutes. A comment from Sarah. Dr. Tartaglia is inspirational because she lets her patients know that they can indeed resolve their symptoms fully. Would she please talk about this perspective that is not shared loudly enough?
I mean, I think you're saying, people, and thank you, but that people, have some control over their symptoms, and that they can, that there are things that can be done, and that that helping some symptoms will automatically just make other symptoms better. And, I think sometimes people have to accept that they have to get treatment for some of their symptoms.
Great, thank you. One last question. What about memory exercises to help with new information?
Yeah, so I often tell people, in learn something new. That's that's how the brain builds up cognitive reserve, by learning. You make synapses in the brain, you make new connections. And so that's how you build up the cognitive reserve. And learn a language, musical instrument, cooking technique, doesn't matter. Just learn something new.
Mm-hmm. Okay, great. Thank you. Okay, we do have one more minute. So one more question. What is the cause of prolonged post-concussion symptoms?
Yeah. Well, it's good to end on that
Yeah.
difficult question.
Yeah.
Yeah, we don't actually know. Like I've said, many different perpetrators have been hypothesized and are being researched, but we actually do not know what the cause is, and why some people recover within days, some people months, sometimes years. We have no idea. Active area of research, which I'm part of.
Great. Thank you very much. Okay, we are right at time now. So thank you very much, Dr. Tartaglia, for the excellent talk and answering all of these questions. This has been great. Just a reminder that everyone will be receiving a very short survey. So if you have a couple of minutes, we always appreciate receiving your feedback. And just a reminder that in 2 weeks, we're going to have Dr. John Rutka with us, and he's going to be talking about dizziness after concussion. So hope everyone has a good evening. Take care.